The last part of the GI PowerPoint lecture is going to actually cover nursing management of the patient with gallbladder, pancreatic, and hepatitis diseases and disorders. The first thing we're going to look at are problems with the gallbladder. Cholelithiasis is a stone formation within the gallbladder, whereas cholecystitis is an acute or chronic inflammation of the gallbladder, and a cholelithiasis is where the stone forms or migrates to the common bile duct. When we look at the pathophysiology of gallbladder disease, remember that bile is formed in the liver and gets stored in the gallbladder, and then this bile gets released through those common bile ducts and the sphincter of Oddi into the intestines. So gallstones actually form when there's abnormal bile composition, when there's biliary stasis, or when there's inflammation of the gallbladder. So 80% of all gallstones are going to be made up of primarily cholesterol. And typically when we think of the prevalence of this, it varies among different ethnic groups, but overall probably about 10% of all men and 20% of all women have been affected by age 65 with one of the conditions that are actually listed here on this slide. Some risk factors for gallstones include the things that are listed here. Women are 2 times more common to have gallstones than men, especially those women that are overweight, over 40, and have our fair complexion. Obesity is a definite risk factor. Middle age, the risk increases with the older that person gets, and any patient that's experienced a real rapid weight loss is at risk. And certain ethnic backgrounds such as Native American, Hispanic, and Caucasian are most at risk for developing gallstones. Pregnancy, multiple births, and use of oral contraceptives is also a risk factor, as well as for those patients that have high cholesterol levels and or have diseases of the ileum. This is just a nice picture that shows you a review of the anatomy of the liver versus the gallbladder and stomach and that type of thing. So the symptoms typically we see with a patient that has gallstones is that there's going to be mild gastric distress, particularly after a large or fatty meal. And if that stone obstructs the cystic duct or the common bile duct, then that patient's going to develop distension and increased pressure behind that gallstone. This can cause that crampy, colicky kind of biliary pain that is typically accompanies gallstones. It's typically found in the right upper lower quadrant. The patient may also have some nausea and vomiting with the episodes. And if that obstruction of the common bile duct is complete, then that patient will start to develop jaundice, pain, and will have liver damage and also possibly pancreatic damage with pancreatitis. It's pretty much diagnosed through ultrasound, elevated liver function tests. Serum amylase may also be ordered to look at the function of the pancreas and if there's an obstruction. And also a test called an ERCP, which is an endoscopic retrograde cholepancreatography. And this actually looks at stones that are within the common bile duct. So on labs, you may also see elevations in the bilirubin levels, the white blood cell count, and also the lipase levels, which is measuring pancreatic function. This just shows a diagram of the laparoscopic cholecystectomy. This saves the patient having to have a huge incision across the side of the abdomen, which if they're not able to do it by lap is what they're going to have to do if they have to do just a routine chole per surgical procedure. With the lap cholecystectomy, this is pretty much standard unless the patient has a particular reason why this couldn't be done this way. The hospital stay for this is usually less than 24 hours, and the patient can usually get back to normal activities within just a few days. They'll have about 4 1/2 incisions that are used to inflate the abdominal cavity with the CO2 gas. Other than that, the patient should have a relatively quick recovery. So please refer to your textbook for a nursing care plan on patients that have had a lap chole. Some teaching points to make sure patients realize that they may have mild shoulder pain for up to a week, and that's due to that infusion of the CO2 into the abdominal cavity. Usually they can get right back to normal activities within just a few days. The patient may have just a little bit of transient diarrhea and dyspepsia, and should always, of course, watch for signs and symptoms of infection in those surgical sites. Alternative treatments, if the patient is not a candidate to have a lap chole done or a complete chole, there are some medications that will help to dissolve the gallstones. One of those is called Actigol, which is an oral dissolution therapy. And for patients that are poor surgical risk, they may go ahead and do this kind of a treatment and try it first. It will gradually dissolve cholesterol stones. The disadvantage is that it may take up to 2 years of taking the medication before this happens. So it's costly and it's just a lengthy type of a procedure. Direct dissolution therapy is another option, as well as extracorporeal shock wave lithotripsy, which uses shock waves to disintegrate the gallstones, similar to what we talked about earlier with renal stones. And endoscopic bile duct stone removal may also be used. The next disorder that we're going to examine is going to be pancreatitis. This is an inflammation of the pancreas, where the pancreas then releases the enzymes that it stores and makes into the pancreatic tissue. And because those enzymes are so caustic, this can actually lead to hemorrhage and necrosis. So essentially, just like is listed on the slide, the pancreas will start to auto-digest itself from its own release of pancreatic enzymes due to the inflammation of the pancreas. So some causes that can set off pancreatitis could be biliary stones, could be alcohol abuse, could be other things. But typically when we look at what happens is that those pancreatic enzymes, trypsin, amylase, and lipase, start to digest the pancreas. There's about 5,000 new cases of pancreatitis per year, and it can be a very, very serious type of a thing because it can ultimately lead to hemorrhage, where the pancreas actually digests so much of itself that there can be breakthrough bleeding, and also there can be perforation. So it does carry about a 10% mortality rate. Symptoms that the patient has with this disorder would be epigastric or umbilical pain that may also radiate to the back, vomiting, which is worsened by the ingestion of food and fluids, and vomiting does not relieve the pain. Patient may have a fever due to the inflammation of the pancreas. Patient may also have signs of hypovolemia due to hemorrhage of the pancreas and fluids leaking out of the capillaries due to all the inflammation that's going on. That can lead to oliguria, the patient having an increase of fluid in the abdominal cavity, which is ascites. The liver may become involved also because of obstruction of bile flow, so it can lead to jaundice. And two classic signs that are seen with pancreatitis are Turner's sign, which is a blue discoloration along the patient's flank area, and also Cullen's sign, which is a blue discoloration around the umbilicus. And that just means that the patient has blood accumulation there from hemorrhagic pancreatitis. So to diagnose acute pancreatitis, some lab levels that will be elevated will be the serum amylase, the serum lipase, and also serum glucose, because remember that pancreas has the beta cells that actually make insulin. And if it's inflamed and not working well, you're not going to have enough insulin produced for the body's needs. So that's why you might see the glucose level elevated as high as 500 to 900. Patient may also exhibit serum calcium levels that may drop due to the necrotic tissue that's in the pancreas. And we've talked about that liver function tests may also be elevated if there's been damage done to the liver. So a good call for nursing or nursing diagnosis for acute pancreatitis, one thing would be pain. So these patients are going to be given frequent pain medication, PCA pumps, to try and keep them comfortable. Typically, they're going to be made NPO to try and rest the pancreas and not have it release all of those enzymes. Remember that the enzymes are released in response to food that the patient takes in. So remember, trypsin is the enzyme that breaks down proteins, amylase is the enzyme that breaks down starches, and lipase is the enzyme that breaks down fats. So typically these patients will have an NG tube in and be NPO. So encourage rest, a quiet environment, and non-pharmacological pain relief such as back rubs and distraction-guided imagery and those types of things. So please see the care plan that's in your textbook that talks about a client with pancreatitis. We talked about also the patients at risk for fluid volume deficit. This can be due to hemorrhage from the pancreas, and the patient also can be third spacing fluids that's actually leaking into the peritoneal cavity due to inflammation of the pancreas. So it's very important to keep a very close eye on intake and output. Vital signs, make sure the patient does not have shocky vital signs, which of course would be decreased blood pressure and tachycardia. Do daily weights, abdominal girths to check for ascites and distension, and monitor labs such as an H&H, potassium, calcium levels, those types of things. To get a close eye on the intake and output, the patient will need to have a Foley urimeter so that you can check hourly I's and O's, and the patient will need to be monitored very closely for elevated blood glucose levels and hypovolemic shock. So typically these patients will initially be in an ICU setting when they come in with acute pancreatitis. Imbalanced nutrition is also an issue because the patients are made NPO, so like we talked about earlier, they will have an NG tube in place. So they may have to start TPN with these patients for nutrition, or they may have parenteral feeding started. So it just depends on how the patient is actually doing and how sick that patient is. So typically the patient should be told to avoid alcohol. That just worsens that whole inflammatory process and can lead to further problems. Ineffective health maintenance, it would be important to get that patient into some sort of a alcoholic rehab program if that is what led to the pancreatitis. And if it's due to biliary disease, discuss treatment for gallstones for the patient. So there's a care plan in your book that you should take a look at that talks about the patient with acute pancreatitis. Patients may also develop chronic pancreatitis, which is where there is persistent and progressive damage to the tissue, and actually fibrotic and scar tissue can replace the normal pancreatic tissue eventually. So with this particular type of disorder, alcohol consumption is about 80% of the cases of patients that have chronic pancreatitis. Obstruction and trauma to the pancreas could also be some causes. Management for chronic pancreatitis is going to be similar to acute. Pain management is important. These patients will have malabsorption syndrome, so trying to correct that. Putting these patients on a low-fat, high-protein, high-carb diet will help. Resting the bowel. And these patients will probably need to be on pancreatic enzymes, perhaps even for life, because the pancreas may not be able to produce the normal enzymes that it can produce anymore because of the damage that's been done to it. Patients also may be diabetic due to the damage done to the pancreas, so they may have to be on insulin due to that. So surgical interventions may be done to relieve obstruction if that's the cause, and otherwise the goal is basically to try to also decrease gastric acid secretions. So these patients may need to be on H2 blockers such as Tagamet and Zantac, and also proton pump inhibitors such as Prilosec. So another med that's actually listed is the sandostatin, which is the octreotide, I guess is how you would say it. And this actually inhibits pancreatic secretion and it may help also with pain control. So that's another med these patients might be on. Teaching for that patient and family would be, of course, getting that patient into a alcohol treatment program, the diet changes and modifications that we mentioned about on an earlier slide, and to teach that patient about the medications they'll be on, and that those pancreatic enzymes are typically taken about an hour or so before the patient eats, or they can take them right with the meal, but it needs to be taken so that they will digest the food properly. Patients that have had chronic pancreatitis are at risk for developing cancer of the pancreas. The most common place that this is found is in the head of the pancreas. 2/3 of all cases, this is where the cancer is located. It's much more common in men, and it's also more common in those men that are over 60. There's a high correlation to cigarette smoking with this type of cancer. There's also a hereditary component, and some of the first symptoms that are seen are pain and jaundice, and also weight loss. So with this one, obesity and a high-fat diet are also a couple other risk factors. And typically it has a slow onset with not a lot of specific symptoms in the beginning. So unfortunately with this one, about 85% of all these patients will seek health care when the cancer has already advanced too far for a cure. So that's the problem and why it has such high mortality rates. It constitutes probably a total of about 2% of all cancers, and unfortunately more than 98% of those patients will die pretty quickly just because it's so advanced when they go to seek treatment. Surgery is really the only cure for this type of surgery. It does not have a very good survival rate. Typically, patients only live about 18 to 20 months after being diagnosed, and the surgery that's typically most commonly done is called the Whipple procedure, and this includes, as listed on the slide, a partial gastrectomy, cholecystectomy, and removal of the distal common bile duct, head of the pancreas, duodenum, proximal jejunum, and also any lymph nodes that may be involved in the area. So as you can see, this is a very, very extensive surgery for a patient to have to go through. And this just shows you an example of the patient that has the illness on the left, and then what the anatomical changes would be after reconstruction with the Whipple procedure as listed on the right. Next, we're going to talk about liver disorders. So we're going to talk about hepatitis, cirrhosis, liver cancer, things like that. As far as assessment and history taken on the patient that comes in with suspected liver disorder, many times you're going to find that these patients are coming in with a lot of fatigue, shortness of breath, skin changes with jaundice perhaps also being commonly noted. The patient may have weight gain and increased abdominal girth because of a third spacing of fluids in the abdominal cavity. They may have anorexia, changes in the colors of the stool, changes in the urine, and they also may come in with vomiting. So many of these patients will have abdominal pain. Part of the assessment would be to look to see if they do have alcohol on a daily basis and how much they do drink. Medications are also known to sometimes cause hepatotoxicity and damage to the liver. So probably some common ones that you've heard of that can do this. One would be certain anesthetic agents such as halothane, anticonvulsant meds such as Depakote and Depakine are known to cause hepatotoxicity. And remember the anti-TB drug INH that we talked about many lectures ago. This actually can cause liver damage. So anytime patients are on any of these types of meds, as well as a whole host of other meds, there's a lot of cholesterol medications that the patients need to have liver damage or liver function studies done frequently, and a lot of chemo drugs also. So many drugs require having the patient have liver function tests done on a routine basis to make sure that there's no damage being done. If we think about what the liver does, it explains why the liver is such at risk for developing problems. Remember, it metabolizes all the protein, carbohydrate, and fats for the body. It also produces the steroid hormones and or metabolizes, I should say, the steroid hormones and most of the drugs that patients take in. It also makes albumin and all the clotting factors. So if the liver's damaged, that would explain why there may be excessive bleeding from a patient. It detoxifies alcohol and other toxins for the body. And it also converts ammonia, which is a byproduct of protein metabolism, converts that to urea for elimination by the kidneys. The liver also produces bile, and it stores minerals and fat-soluble vitamins. So the liver has a lot of functions, and you can see why, if it's damaged, that there would be a lot of different problems that the patient would have based upon their liver function not being what it should be. One of the first signs and symptoms that may be noticed with a liver disorder is that there's going to be changes in the color of the skin and also the changes in the color of the whites of the eyes. Remember, that's called scleral icterus. And remember, patients that do have jaundice and an increase in bilirubin in the skin will typically have very dry skin with lots of itching. They may have redness in the palm area. They may also have petechiae and ecchymosis noted because of clotting factors not being produced as they should be by the liver if it's damaged. The abdomen can appear very distended. That picture to the right is an extreme case of ascites, but it can get quite distended and taut. You can see the distension of the veins, and you can start to see eversion of the umbilicus. For those patients that do have ascites, you can actually check for fluid waves. And the patient that's in the picture actually doesn't have ascites to the point where you could actually be able to see a fluid wave. They would have to have quite a lot of abdominal distension to be able to pick that up. But the picture is just trying to depict to you how you would actually check for that fluid wave. The reason that the patient develops ascites is because of increased pressure in the abdomen on those vessels, and that causes the fluid to move out of the vessels and into the peritoneal cavity. So that's actually why you see that. And portal hypertension is also involved. So some diagnostic tests that we can look at to look at function of the liver would be the liver enzymes. AST, ALT are probably the most specific. We can look at total bilirubin counts, either direct or indirect, and also prothrombin time. Remember, the liver does all the clotting disorders, so we can look at if it's able to use vitamin K and produce those clotting factors as it should be. Also, albumin levels, decreased production of albumin by the liver can lead to hypoalbuminemia, and also we may see ammonia levels being elevated because the body can't convert ammonia to urea for the kidneys to excrete. One way to diagnose liver problems would be a liver biopsy. So make sure that patient has bleeding studies, clotting studies, consent form, vital signs, all those types of things checked before this procedure would be done. Typically, we're going to see exposure of the right upper abdomen, have the patient coordinate breathing with when they go in for the biopsy. And afterwards, we want to turn that patient to the right with pillow support, avoid straining, watch for bleeding, and have that patient avoid strenuous exercise for about a week. Another procedure that may be done just to relieve all that pressure in the abdomen with the ascites is a paracentesis procedure. And we always want to get a set of baseline vital signs before the procedure. Depending on how much fluid is taken off of the abdominal cavity, that patient can go into hypovolemic shock. So at one particular sitting, that patient could have up to 4 to 6 liters of fluid taken off of the abdominal cavity, which would be a huge amount. So for these patients that are if they're going to draw off quite a large amount of fluid, we would want to make sure that they're getting albumin IV and IV fluids to maintain their intravascular volume as we take all this fluid out of their abdominal cavity. So typically this is done under a local anesthetic. The patient's positioned for the procedure. As you can see, sitting up in a chair is fine. and vital signs are monitored for these patients. Afterwards, it's important to make sure that their vitals stay stable and that that fluid is sent down for analysis and to check the site for signs of infection or problems. One disorder of the liver that I'm sure all of you have learned about in the past is going to be hepatitis. Remember, hepatitis is basically an inflammation of the liver, and its most typical cause is usually by a virus, but it can also be due to other things such as alcohol, drugs, and other toxins. Patients that have chronic hepatitis are at increased risk for liver cancer and also for cirrhosis of the liver. And just remember, as a quick review, there are 5 viruses that can cause hepatitis. There's A, B, C, and then there's one that's called B with a delta virus, which they usually refer to as hepatitis D. And then there's also hepatitis E. So remember, all these different types of viral hepatitis will cause similar symptoms, but they will differ in the modes of transmission and also the incubation periods and the severity of the symptoms that you may see with the patient, and also if that patient can become a carrier or go into a chronic state with the hepatitis. Remember, the 2 that are the fecal-oral route are hepatitis A and hepatitis E. Hepatitis B, C, and D are the blood and body fluid route. There's different clinical symptoms that you'll see with these patients. When they're in the pre-icteric stage, in other words, they haven't had jaundice developing yet, the patient may just come in with some vague symptoms of fatigue, anorexia, nausea, joint pain, and upon lab values it may be noted that they have elevated liver function tests. When they're in the icteric or jaundice state, these patients will have that dark urine, clay-colored stools due to the bilirubin, and will have right upper quadrant pain and increased itching due to the jaundice. And then the labs will pick up, of course, on those elevated bilirubin levels. And in the post-icteric state, the patient will have the jaundice starting to decrease, the lab values starting to come back to a normal range, but that patient will have fatigue for quite some time. Other diagnostic tests, they can actually run viral antibody tests. Medications that can be given would be vitamin K for prolonged prothrombin time. Analgesics are usually used sparingly because remember that the liver is the organ that detoxifies all the drugs that are given in the body. Treatment is basically to rest and to do diet modification with a low-fat, high-carb diet and restrict protein and sodium values on these patients. Remember, a couple other preventable things are that hepatitis A has a vaccine that can be given to combat against that, as can hepatitis B, which you all know about that because you had to get it to come into nursing school. And there is also a combined hepatitis A B shot for those patients that are a high-risk population and that they want to try and get them vaccinated for both at the same time. So if that patient would develop some sort of hepatitis, usually they're given, especially with hepatitis A, prophylaxis immunoglobulin. If you're given that within 2 weeks of exposure, there's a good chance then you won't come down with the disease. Same with hepatitis B. We can actually give HBIG, which is hepatitis B immunoglobulin, and that will kind of help, as well as giving an antiviral type of medication. As far as other good nursing diagnoses, imbalanced nutrition, less than body requirements is another important one. So these patients are given fluids, monitored for intake and output, and are to limit fat, limit sodium, and try to do smaller, more frequent meals, and of course to avoid alcohol. As far as pain, comfort measures for headaches and arthralgias are given. They may try to do some things such as just back rubs and dark environments and those types of things, and try to avoid much in the way of narcotics because of the possible toxic effect. And like we talked about earlier, their skin will be itchy, so there's some good suggestions for those issues. As far as fatigue and activity intolerance, trying to balance rest with activity and good nutrition for energy is going to be helpful. Some preventative measures we talked about earlier, that hepatitis A does have actually an immunization that's available for that. Although patients will get, I don't remember exactly the statistics, but they'll get good immunity after one shot, but typically 2 are recommended. So it's a 2-shot series for hepatitis A. With this one, remember, it's the fecal-oral route, so make sure that these patients you know, have a lot of education on reporting outbreaks and knowing how to try and prevent this from happening. One of the floors that I worked on a long time ago, actually, several of the nurses came down with hepatitis A. We had a potluck on one of the weekends when we worked, and unbeknownst to us, one of the patients must have had hepatitis A, and there must have been one of the workers on the floor that participated in the potluck that didn't do good hand washing, and needless to say, there were several people that ended up having hepatitis A because of that. To prevent hepatitis B, remember to try to interrupt the chain of transmission. So disposing of needles properly, using safety syringes, standard universal precautions, and to try and get people in the community immunized against hepatitis B. As we all know, that's a childhood vaccination that's now required for children to enter the school system to get that series. Passive immunization can be given through that, what we talked about earlier, Hep B IG, so that's that immunoglobulin for people that have had exposure to the hepatitis B and who've never had the vaccine. So typically we want to give that pretty quickly after their exposure to have the best outcome. Hepatitis can cause ascites just like some of those other disorders that we talked about earlier. So this just shows an example of a patient with extreme ascites. Cirrhosis of the liver is the next disorder that we're going to talk about. There are basically different types of cirrhosis. One can be from alcoholic intake. It could be post-necrotic, or it could be biliary, also types of cirrhosis. Usually alcohol is going to be the culprit that's going to be caused. Remember, cirrhosis is actually end stage of chronic liver disease. It's progressive, it's irreversible, and cirrhosis leads to liver failure. It's 2 times as common in men as it is in women, and it's actually considered the 12th leading cause of death in the United States. So remember, when that patient is an alcoholic, that the alcohol damages the hepatocytes, which are the liver cells, and what happens is there's fat accumulation in those cells, which leads to cellular necrosis and inflammation. That can cause fibrosis and scarring, where the liver then shrinks and becomes very hard and nodular, which is actually the picture that you see down in the lower right-hand side of the slide. This whole process can lead to portal hypertension, where there's obstructed blood flow from the portal vein, and it can also lead to varices of the esophagus, the stomach, and the rectum, splenomegaly, ascites, and also hepatic encephalopathy. So just to review the patho, remember the common signs and symptoms and manifestations that patient will present with are jaundice, pruritus, which is that itching, bleeding tendencies, hepatic encephalopathy, and portal hypertension. And please review your patho in your book, why these things happen, and also the signs and symptoms that patients will have. One complication we mentioned is the esophageal varices. Varices are enlarged, thin-walled veins, and what happens with this is that patient can actually start to bleed out. We've already talked about ascites. There's a picture of an extreme case of ascites to the right. To manage ascites, remember, we'll do the sodium restrictions, fluid restrictions. We can put these patients on some medication to try and pull off that weight. So we can give them things like diuretics, like Lasix, and also aldactone, which is a potassium-sparing diuretic. We can also give them laxatives. Lactulose will help to actually pull off some of the toxic compounds, and we can give them anti-infectives and things like that. Paracentesis we talked about in an earlier slide. This is actually when that abdominal fluid can be removed, and like I said, they can take up to 4 to 6 liters at a time if needed. Management for those esophageal varices is going to be typically medications. Common medications are vasopressin, which will actually lower that portal hypertension by causing vasoconstriction. Inderal may be given as a beta blocker to reduce portal pressure and to help decrease with potential bleeding. And then also the sandostatin will decrease that portal hypertension. So another thing that can be used is a balloon tamponade, where they actually put a special tube in where they can put pressure right up against that varices to keep it from bleeding out, because that is the risk with esophageal varices, is that they can eventually blow and that patient can hemorrhage out. Other things that can help with management of the esophageal varices are sclerotherapy, the TIPS procedure, and also surgical shunts. So the TIPS procedure is actually considered a transjugular intrahepatic portosystemic shunt type of a thing. So there's a shunt actually put in between the hepatic and portal veins, which decompresses the whole portal system and can help to decrease then portal hypertension. So this usually is only done if like medications and sclerotherapy and the balloon tamponade have not worked for that particular patient. So this just shows you some of those different things that we talked about on the last slide as far as potential treatment for these. The patient that has cirrhosis of the liver and extreme liver disease may also start to develop what's called hepatic encephalopathy, which is actually mental changes and neurological impairment due to all the toxins that have built up in the system from the liver not working. So the patient may be restless and agitated, have impaired judgment, slurred speech, and this is all caused from accumulation of the neurotoxins in the blood, and also this patient has cerebral edema because of it. Also the fact the patient can't break down ammonia anymore and they have toxic levels of ammonia adds to this whole problem. So one thing we see as far as a symptom of this is the patient has what's called hysterexis, which is where the patient actually has hand flapping. If you have the patient extend their arm and dorsiflex the wrist, you'll notice that their hand will go into like a flapping type of a position. So it's just one of the symptoms we see with patients that have this particular type of problem. This shows a patient that has hepatic encephalopathy and just shows the damage that's been done. To manage that, the patient's put on dietary restrictions, of course, once again, reducing protein, increasing carbs, and they're actually put on medications. Lactulose will actually help to excrete the ammonia in the colon, so it'll help to bring down those ammonia levels that the patient has. Other medications, neomycin, may also reduce the absorption of ammonia in the GI tract and can help to bring down those levels. So the patient is not to use narcotics or sedatives or tranquilizers, because remember, if the liver's not working, we can't have those drugs detoxified then, and they can have excessive levels build up in their bloodstream. Breathing may be an issue. In particular, think of also that patient with huge ascites in the abdominal cavity. So putting them in high Fowlers, turning frequently. They may need thoracentesis. They may also need paracentesis for the ascites if that's what's causing problems with breathing. Excessive fluid volume, we need to monitor the potassium levels. Sodium restrictions are going to be still maintained, put on diuretics. Albumin will help with the vascular system, and the patient will need to be on fluid restrictions, daily weights, and daily abdominal girths also. They are at risk for injuries and falls, and also at high risk for bleeding because of not having the clotting factors available that they need, and also because of poor vitamin K absorption. So for these patients, we need to make sure that we're monitoring them for injuries and for environments that may be injurious to them, and then also checking for any signs in bleeding that are noted on the slide here. So check urine and stool for blood, look for mouth and gums for blood, check for any bleeding in the skin. So look for purpura, hematomas, petechiae, watch for shocky symptoms, so keep a close eye on vital signs, monitor their prothrombin and PTT values, and monitor platelets. The other thing that these patients will have issues with, we've talked about already, is nutrition. They'll need protein limited because they can't break it down, and also remember a byproduct of protein is ammonia, and they already have too much on board as it is. So they're typically put on protein and sodium restrictions. The last liver disorder that we're going to talk about is liver cancer. Liver cancer is about 2% of all cancers in the United States. However, worldwide, it's very common. If we look at certain areas of Asia and Africa, they have almost 500 cases of liver cancer for every 100,000 people. So it's not as common in the United States as it is in other parts of the world. It's highly linked to chronic hepatitis B and C, and unfortunately, most clients die within about 6 months of receiving the diagnosis of liver cancer. Typically what brings them in is abdominal right upper quadrant pain, weight loss, anorexia, anemia, hepatomegaly. It's diagnosed by liver biopsy, CT, and MRI, and the management of it is to remove the part of the liver that's cancerous, radiation and chemo. This can either be given in an implanted method or as an external pump. And last case resort would be that the patient would need to be on the organ transplant list for a liver transplant. These are used to treat life-threatening end-stage liver disease when no other treatment has worked or no other treatment is available for these patients. So liver transplants are going to be used for those patients also that have irreversible progressive cirrhosis. And post-op complications after a transplant, there's always risk for bleeding, risk for infection, and risk for rejection of the liver. So those patients are going to be on immunosuppressants for life, steroids, cyclosporin, those types of things. And this just shows an example of a diagram of a liver transplant. So that ends the GI lecture. Refer to your book. There's a lot of good tables and a lot of good nursing care plans and those types of things in the readings that will help to explain it even further. So